Hello and welcome to this webinar. I'm your moderator, Dr. Jonathan Sakia. Our goal for today is to answer the question, what more can you do to help your pediatric patients with recurrent viral wheezing? This webinar is brought to you by OM Pharma and is hosted by EMG Health. Today, I'll be talking to three experts following their symposium with OM Pharma at the 2020 European Respiratory Society International Congress. We'll be endeavoring to answer a series of questions that are frequently asked and that unfortunately there wasn't time to address during the Congress. First, Professor Manuel Soto-Martinez from the School of Medicine of the University of Costa Rica, a very beautiful country. He spoke about respiratory tract infections, RTIs, during childhood, their complications, and disease burden. Saludos, Professor. We also have Professor Wojciech Feleszko from the Medical University of Warsaw in Poland. Witam, Professorze. And Professor Alexander Möller from the University Children's Hospital in Zurich, Switzerland. Und willkommener, Professor. Both Professor Feleszko and Professor Möller spoke about the role and evidence for immunotherapy. Welcome, gentlemen, and thank you for joining us for today's webinar. I'd like to kick things off with a question for Professor Soto-Martinez. In the context of COVID-19 and based on your expert opinion, which measures would you recommend to prevent respiratory tract infections and complications in children and other household members, and why?
Thank you, Jonathan. So there is no doubt that COVID-19 has changed our lives. And although all respiratory infections worldwide probably, besides COVID-19, have decreased in prevalence, they remain common in children and still with a high morbidity. And as you can see the numbers, at least for COVID, see how up to now we are over 48 million cases worldwide and more than 1.3 million deaths around the world. Now, what it usually happens in the middle of the pandemic, no one wants to get sick. And this has led to an increased amount of publications, commercials, and people selling things to kind of suggest an immune boosting or protection to get children or people out of hospitals. But not all the things that you see in the slides might be true, and the evidence is not very strong for most of these products, as you probably know. What has really made the difference is basically washing hands, the long-term implementation of using masks and keeping the distance. And this is not only true for COVID-19, but also for other infections. And one of the things that we have seen in many reports around the world is a decrease in cases of pneumonia, diarrhea, and other sort of respiratory infections. But for me, one of the main points or one of the main important things that you have to make sure in terms of preventing people from getting sick is identifying those who are at high risk of COVID-19. So if we know that there are all older adults or people with underlying medical conditions, that might have an increased risk of getting severely ill, you probably should identify those people, and maybe if they live with children, and children particularly if they're going to school, probably you have to separate them from this child. Or in addition, if you have children or adults with chronic conditions, for example, asthma, or in adults, COPD or diabetes or hypertension or obesity, probably you should be very adherent to your control treatment medication to avoid exacerbations and avoid going to emergency rooms. Now, as you probably know, this story is still being written, and COVID-19 is nothing until now that has significantly decreased the amount of cases, and we're seeing third waves all around the world. And I think that to get back to normal, what we need is a vaccine. But for the time being, we need just more restrictions to prevent people from dying.
Thank you very much, Manuel, for those very clear, cogent, and very sensible observations. I'd like to pose another question. Based on your knowledge and clinical experience, which patients could benefit further from prevention with immunomodulation?
In my opinion, I think that we can have 4 different patient profiles that can probably benefit the most from immune modulation, particularly by bacterial lysates. So one will be the children with recurrent respiratory tract infections. The second one will be the asthmatic patients that will have recurrent respiratory viral exacerbations. The third group of people, of children, will be those on high risk for asthma. For example, the kids with recurrent wheeze. And the fourth point, and look at the question mark because I mean there's still studies going on, is probably looking at primary prevention. So how can we prevent children from getting wheeze and getting asthma in the future? And I mean, just to show you some evidence to support my answer, I wanted to show you some studies. So in this first study, this bacterial lysate, OM85, was given to a group of children between the age of 1 and 12 years old. And as you can see, it was effective in decreasing the number of infections, the number of antibiotic courses, and the total duration of symptoms compared to the placebo group. Now you can see it's a small number of children, it was just 54 children. This other study was done in Mexico in an orphanage. And as you can see, bigger numbers, they selected 200 girls aged 6 to 13 years of age with a history of recurrent respiratory tract infections. And this was a double-blind but randomized placebo-controlled trial. And at the end of the study, what they showed is that patients in the OM85 group, as you can see in light blue, experienced less infection and, interestingly, less severe infections than the control group. Now, in a more recent double-blind placebo-controlled study by Susanna Esposito in Italy, they showed a significant reduction in the number of respiratory tract infections and antibiotic use in children less than 6 years of age who receive OM85. And in addition, there was also a reduction in daycare and work absenteeism. So in the second group of patients that we mentioned that might benefit from immune modulation were the asthmatic patients. And I think this will benefit the most because they are the ones who suffer frequent infectious exacerbations, particularly viral exacerbations. And in this study, they included 62 patients aged 5 to 15 years of age with asthma and recurrent respiratory tract infections and wheeze. And as you can see also in light blue, is that the group who received OM85 showed a 58% reduction in respiratory tract infections and a 50% reduction in asthma attacks. Now, the third group of patients that I mentioned that will probably benefit will be the high risk of recurrent tract infections and wheezing illnesses. And in this study that was quite recently, 200 children between 3 and 6 years of age with a history of at least 6 respiratory tract infections per year were included in the study. And they received OM85 for 2 consecutive years versus placebo control. And as you can see in this slide, this slide is the results from the first year of OM85, and the second year is pretty much similar. But at least in this group of patients who were kind of the sickest group of patients, the children in the OM85 group showed less upper respiratory tract infections, less wheezing illnesses, and less antibiotic use or courses than the control group. And also probably very famous study by Rassi and colleagues. In 75 children between 1 and 6 years of age with a history of recurrent wheeze, OM85 led to a 38% reduction in the number of wheezing attack episodes, 31% less reduction on respiratory tract infections, and less duration of symptoms compared to placebo control group for a 12-month period. So, I mean, suggesting that probably OM85 might be used as a complementary therapy in this group of children. And the fourth group that I mentioned that were the high risk for developing asthma group probably, this was a randomized clinical trial performed in Australia in which they took around 59 high-risk infants between 3 and 9 months of age, and they gave OM85 or placebo 1 month before and during the winter months. And in some of the results of the study, which I think were quite interesting, they showed a longer time to get their first severe lower respiratory tract infection, the group who received the OM85, less cumulative frequency of episodes, and less days of symptoms. And this probably could mean less inflammation in this high risk group, less damage, and probably less risk. So, I mean, just to wrap up my answer, and you can see the checks there, I mean, I think it's worth considering that in most of these studies, probably in all of these studies, these bacterial lysates as immune modulators, they were safe and they were quite well tolerated in these children, and they probably kind of seem to help decrease either the frequency or the severity of inflammatory damage in this group of high-risk patients.
Thank you very much, Manuel. Even to a simple surgeon, that's clear and very encouraging data. So thank you for that. Moving on, I'd like to ask a question to Professor Feleszko. Does immunomodulation with OM85, is it more of a local or a systemic effect?
Thank you, Jonathan, for introducing me to this lecture. First of all, I would like to mention that there are products on the market for at least 30 years. They have been composed out of bacterial antigens, including OM85, but also many others. And they have been thought initially to be a kind of vaccine. So we provide orally bacterial antigens in order to induce antibacterial immune response. Meanwhile, we became aware that most of the infection, as my previous speaker today mentioned, are of viral origin. So it looked for us unexpectedly interesting to find out what is the mechanism behind this antiviral and anti-infectious effect. And what was found out, and evidence is actually accumulating for the last, let's say, 10 or 15 years, that upon ingestion of bacterial lysates, including OM85, but also mechanical bacterial lysates, they induce an activation of mesenteric cells. They are found in Peyer's patching. And the most important cell, which is depicted here in the middle of this graph, is the dendritic cell. So they become activated, they ingest more antigens, they tend to migrate from Peyer's patches. They also induce a local immune response within the mesenteric mucosa. And what happens then is they take a trip through the lymphatic circulation towards different mucosal organs. So what was found out additionally is the presence of activated and antibody-producing B cells and fully activated T cells. They migrate towards mucosal tissues. And as a result of that, we find in the airway mucosa a bunch of phenomena. They explain us an antiviral and anti-infectious effect of bacterial lysates, including OM85, which is increased activation of T cytotoxic lymphocytes. They are crucial for effective antiviral response. They also there are also macrophages and NK cells present in the mucosa that are able to fight against invaders, increase local production of IgA, but also epithelium, the first barrier, the first wounded soldier combating against infection, becomes more strengthened with increased production of interferons alpha and beta, decreased expression of ICAM molecule, which is a hand depicted here in blue at this diagram which enables the virus to invade the cell. And as a result of that, bronchial epithelial cells are less likely to be infected. So to sum it up, we have two effects: a local effect, both in the mesenteric mucosa as well as in the respiratory tract, but we have also a systemic effect, including increased number of activated B cells, T cells, and increased antibody production.
In the context of COVID, could the use of OM85 actually worsen respiratory symptoms by a mechanism of increasing the risk of cytokine storm?
Thank you, Jonathan. This is a very vulnerable question, since we all are looking for effective remedy against SARS-CoV-2 virus. So to make a long story short, I have shown previously that there is a general immune response with the dendritic cell. And the dendritic cells, upon activation with bacterial antigens, bacterial lysates, become activated. And they do produce a bunch of different cytokines. They induce a bunch of cells. However, most of those cells and cytokines are not responsible for cytokine storm. So they are responsible for the production of potent antiviral cytokines, which in the context of recent reports published recently in Science shows a potent antiviral response also in the context of COVID-19. But beside of that, what was found out in recent years was that these products, OM85 and other bacterial lysates, also do induce regulatory response. So in other words, they also dampen exaggerated immune response in terms when it's necessary, for instance, in asthma and allergic diseases, which was found and demonstrated beautifully in several studies. So summing up, we do not expect bacterial lysates to contribute to the cytokine storm, which is seen in the context of COVID-19. However, there is recently accumulating evidence about so-called trained innate immunity. And let me devote a couple of seconds to introduce this concept, being mainly investigated by the group from Rotterdam, Mihai and Etia, who published recently a couple of beautiful, amazing papers in Cell, showing that not only antigen-specific immune response, the adaptive immune response can be trained, can be educated. What we also see in innate immune response, when exposed to certain bacterial antigens, they show switch to proactive state. They are epigenetically reprogrammed to get a higher state of activation. In other words, the mucosal tissue becomes more prepared towards viral infections, including SARS-CoV-2. And this is the hypothesis being proposed by the group from Netherlands, just recently published in Cell, showing that in normal individuals, in which the immune response is resting, when they are exposed to pathogen, SARS-CoV-2 virus, the pathogen invades those individuals without any specific and exaggerated action from the innate response cells. So transmission of this pathogen is effective and these people become ill. However, if these individuals have been previously boosted by certain products, including BCG and other pathogen-associated molecular patterns, including bacterial lysates, we don't have enough data to talk about bacterial lysates. However, basing on a BCG story, we can assume that this is an effect which can be seen also in patients ingesting this product, is induction of trained immunity, higher level of activation of those cells, and then upon exposure to a pathogen, it cannot be transmitted and these individuals do not become ill. So this is a fascinating subject which deserves a special attention, especially with the coming months. Thank you.
Yes, thank you very much, Wojciech. Finally, I'd like to pose a couple of questions to Professor Möller. Firstly, how many courses of OM85 can be repeated per year?
Yeah, thank you again for this question. Actually, I would probably formulate the question a little bit different, because it's probably more interesting to know if how many can be done, but how many should be done. So I disentangled the questions a little bit in two parts. So the first question is there any evidence for the number of courses per year? So should we do like 6 months, 3 months, 12 months in a row? Or is there any evidence for repeated courses during several years? So I think this is giving us probably a better answer than just asking how many times can we repeat. So I'm coming back actually to the studies that have been already discussed at the ERS conference, but also prior from Manuel. So this is the study from Susana Esposito. It's a randomized control study, a placebo-controlled study in 288 children, age 1 to 6 years, presenting with recurrent respiratory tract infections. And what they did here is, you see it in the graph, that they compared 3 months of OM85 to placebo. So this is group A in the top and group B in the middle. However, they did also a third group, which was more an exploratory part of the study, which included a third of the population, where they got actually 6 months of OM85. So we can use this study to explorate a little bit whether it is worthwhile to continue over 6 months or if we should stick to 3 months. So you know already a little bit these results. What the main outcomes show is actually that we have a significant reduction of respiratory tract infections in both groups that got OM85, such as for 3 months and 6 months. So respiratory tract infections generally, otitis media, and also as a result of this, antibiotic prescriptions. And this benefit was maximal in children that presented with more frequent respiratory tract infections prior to the study. And what Manuel already mentioned is, and I found this actually a very important outcome that is always a little bit discarded in many studies, because we are pediatricians and children are on the one side cared by the parents. So if a child is ill, the mother mostly stays at home. So if you have parents that both work, one of the people will lose the work days. So the outcome of lost working days lost by parents, I think, is a clinically very, very irrelevant outcome. So, and this was significantly reduced also in both the children treated with for 3 months or for 6 months. However, coming back to the wheezy children, there was in this single study no reduction in wheezy episodes. So if we now look at the difference between group A and C, so meaning we compare the children that have been treated for 3 months in comparison to those children that have been treated for 6 months, we don't see actually differences in pretty much any of the measured outcomes. So when you look carefully, there seems to at the wheezing line, there seems to be a tendency to a further reduction of wheezy episodes when you treat longer. So we could actually conclude of this study that 3 months seems to be equal to 6 months. However, I have to say that this study was underpowered because the third arm was an exploratory study part and 3 times less subjects. So the comparison is not to take, is to take a little bit with care. So should we do it repeatedly over 12 months instead of just adding up 3 months and another 3 months? So this is also an interesting study published about 9 years ago. So they also included, this was also a placebo-controlled prospective study, including a group of 45 children aged 1 to 12 years. However, the children were actually in the younger part of this population, so the mean age was about 4 years, presenting with recurrent tract infections. And so what they did, they had 2 arms, a placebo arm and a treatment arm, and they gave OM85 or placebo for the first 3 months of the study, and then there was a period of 6 months without the drugs, and then again 3 months of treatment to end up. And the follow-up was 12 months, and children were assessed every month, and using a symptom severity score assessed by a visual analog scale. So what you can see on the left side of the panel is that the upper airway tract infections and lower airway tract infections and otitis was more or less halved in the verum group. And on the right side, you see actually a nice presentation of how this was actually during the year. So on the black circles, so the full circles are the children treated with OM85 bronchobuxom, and the other with the empty circles were the placebo children. And you see that for all the single months, despite of 1 month, which was April, there was a reduction of the mean incidence of airway tract infections in the treated children compared to the placebo group. And there was like a waveform that reflects probably a little bit the viral infections. And this is a survival plot. You can see actually that the time to the first exacerbation was reduced by OM85, so they took longer to have a first infection. But this is specifically shown here for children with many respiratory tract infections, meaning more than 6 in the last 6 months. So the question is, now we have 3 months, 6 months, or 6 months in a period of 12 months. Should we just repeat it over several years? And this is the other study has been already discussed by Manuel. And what you can see here is actually a retrospective study, which was a controlled open label study, including 400 children, so a big group of children, again in the preschool age, presenting with recurrent tract infections. And the study was done in 2 consecutive years. So children were treated for 3 months in 1 year and then 3 months in the next year. And you see that actually the groups were balanced between 200 children that were treated and 200 children were not treated. And you see the main outcomes. So there was a reduction in respiratory tract infections. And also, in difference to what I showed before from the same study group, is that the number of children presenting with any wheezing in this period was reduced in the children treated with OM85. So it looks like that a more prolonged treatment might result also in a reduction of wheezing episodes. And also the severity and number of infections were both reduced. So if you now look at the difference between the 2 consecutive years, I think this is interesting. So this data has not been presented, so I calculated the differences myself with taking into consideration the numbers in this table. So when we compare the first year and the second year, there was no difference in the rate of infections. However, if you look actually the number of children with any wheeze was actually further reduced in the second year of treatment compared to the first year of treatment. There were no difference in the antibiotic use. There was a slight trend in the outpatient clinical visits, and the number of lower airway tract infections was actually only significant in the second years. So what I conclude from this quite elegant open label study, this is a limitation I have to say, is that it makes sense if you consider to treat the child to do it for 2 consecutive years.
Thank you very much for covering that so nicely, Alexander. It's very, very clear. Final question for you. Can OM85 be administered with a flu vaccine? Is it well tolerated?
Yes, I think this is an important question, and it's more important actually this year because the flu vaccine has been pushed a lot, and there is a lot of consideration to actually give the vaccination to many children as possible. And maybe also it will be important when it comes to a vaccine against COVID-19 or SARS-CoV-2. So I think this is a good base for this type of questions. So Susana Esposito did actually this study, and I think it's good that this study has been carried out. This was part of a prospective randomized single-blind study, including 68 children aged 36 to 59 months, again presenting with recurrent respiratory tract infections. So the definition here was they had to have 6 infections in the last 12 months. So again, when they compared actually children that were treated with OM85 and got a flu vaccine, these were 33 children, compared to children with respiratory tract infections that were not treated with OM85, but vaccinated for the flu vaccine. Similar comparable group. So what you can see is that OM85 reduced the number of upper respiratory tract infections, which is expected from the other studies. And again, there was a reduced antibiotic use and a reduced day of loss from school, and translated to the parents maybe also loss of working days. So in addition to the flu vaccine, there is quite clear that OM85 is active. But the question is whether there is any negative interference with the vaccination. So this is a little bit complicated and populated slide. Sorry for this. I just can actually give you the results. On the left panel, you see the seroconversion data for 28 days and 90 days with different measures. And what you can see is actually there was no significant difference in the seroconversion rate and amount of seroconversion in the children that got OM85 in addition to the flu vaccine. And on the right panel, A and B, you see actually the specific response by IgM and IgG. And what you can see is interesting and might lead to some discussion is that the IgM response seemed to be a little bit higher in the children that didn't get OM85. But this was not the case for IgG. So IgG response was similar or equal in both groups and were clearly significantly different compared to the pre-vaccination levels. The question is there additional side effects? You could imagine that if you have an activated immune system getting a flu vaccine, you could react more to the flu vaccine. This was not the case, so the flu vaccine did not lead to high rate of erythema, swelling, or pain when the children got the flu vaccine. There was also no evidence that children had more fever, so there was just one child in the OM group and 2 children in the vaccination group. Neither like other signs such as irritability, sleepiness, vomiting, diarrhea, or something else. So what you can clearly say is that it is safe and well tolerated, and it doesn't produce any more side effects from the flu vaccine. So 2 results that seem to be important here is flu vaccine is not affected in regard to efficacy for the flu vaccine in sense of immune response, seroconversion, and getting actually a flu. And on the other side, OM85 did not lead to more pronounced symptoms from the flu vaccine.
Well, thank you. That's very encouraging. Obviously, in these times, flu vaccination for these patients is something that we need to be thinking of. Gentlemen, really interesting discussion today. I'd like to start by thanking Professors Soto-Martinez, Feleszko, and Möller for joining me today to talk about what more we can do to help pediatric patients with recurrent viral wheezing. And I shall go to bed less done tonight. So thank you very much, gentlemen. I'd also like to thank OM Pharma for their support of this webinar and EMG Health for hosting and handling all the complex logistics across multiple nations. Most importantly, thank you, our audience, for joining us today to hear more about this important topic. Knowledge vaccinates us against ignorance, and as physicians, our commitment to learning drives us to deliver better patient care, something I know that we're all passionate about. Please stay safe, stay well, stay curious. Thank you for the privilege of allowing me to host this webinar. Bye for now.